the flip side, it's sweet for me because I get to introduce Steve. He's been my mentor-in-chief from my days at UT Southwestern, and he's the one who got me into medical AI, part of the Maya, the medical AI and automations lab that he's the director of. Steve is also the Barbara Crittenden Professorship in Cancer Research and the Vice Chair Digital Health and AI and the Division Chief of Medical Physics and Engineering back at UT Southwestern in the Radiation Oncology Department. So I'm very excited to introduce Steve, and he's going to talk about something that he's very passionate about, personalized patient care. And he's building this whole ecosystem around having experts, in this case physicians, doctors, researchers, and all the other resources to help out with the data that's available to build AI systems that truly can be an impactful way to help patients at the clinic. So without further ado, I'll hand it over to Steve.
Thank you, Tim. Thanks for the invitation. I'm glad to have an opportunity to share some of our work and thoughts on an interesting problem when you try to deploy AI in clinical practice. So how do I advance this slide? I don't see any buttons. Okay, thank you. So first, I'd like to thank my colleagues in the Maya lab for their contribution to this talk. Next slide. So we all know, right? Ideally, deep learning models should be trained with large, representative, and high-quality annotated data sets. But in real world, clinical world, we often have to deal with very noisy small data sets, right? There are a lot of research efforts addressing this problem. One type of noisy annotation problems are expertise errors. That's due to the human subjectivity. So the conventional wisdom dealing with this type of noisy annotations, number one, try to achieve consensus from a group of expert observers. So that's how typically, if you read those papers when they try to deploy AI in medicine, that's how people do that, right? Another way, of course, is during your model training, you can have all kinds of tricks to mitigate the adverse effect of this kind of noise in the data. So by doing that, you basically assume there is one ground truth for this data labeling, and all the noise are from some errors, so that you try to reduce that. But next slide. But in reality, there is not always a single ground truth, right? So there could be multiple so-called ground truths there, because a lot of times in medicine, the clinical problem is an underdetermined problem. There are two major sources for human subjectivity-related data annotation noise. I call it type A and type B. Type A, that's mainly due to the lack of experience of the clinicians. Type B, that's mainly due to the lack of information about this particular clinical problem, right? So basically for type A, that's because when the expert observers, aka like clinicians, when they label the data, or when they try to come up with a treatment strategy for a particular patient with a particular disease, they are not very sure what's the right thing to do, or there is no one ground truth, and they may have to come up with a decision based on, whatever they know, right? But they are not very sure about it. So this type of variation can be reduced with increased experience. So they will do a better job with more and more experience in the field. And also with additional training that can help to reduce this type of noise. And of course, you can develop AI tools to assist them to come up with more consistent clinical decisions or data labeling, right? So this is actually an important area where you can use AI to improve healthcare, to reduce the healthcare disparities. So next slide. But for type B type of problem, that is not that simple. So the main reasons for type B variation include different training background, personal experience, and personal preference. So three reasons for type B. So different training background mean like depending on where you are trained, you'll be likely take this type of this particular protocol or technology to treat these patients with this specific disease, right? So that is not like I said, not one single solution. There might be multiple from different institutions. You may have different solutions, right? So typically people do not want to change because this is a habit for them. But if you have some sort of institutional policy, for example, all the physicians working in this hospital have to follow the same guideline, and then they may do that. The second reason is due to the lack of evidence to support one single ground truth. And in that case, clinicians may be very experienced and they trust their own judgment based on their experience and their instinct. And to reduce that kind of noise, you need to have new evidence. You need to have a strong evidence telling them, hey, this is not the optimal way to treat this type of patients. You have to go to another way, right? But in reality, it's very difficult to come up with that type of solid evidence. So most of the time, you just cannot convince them. So the third reason is more like how they handle trade-offs. Life is full of trade-offs. So is medicine, right? Such as, for example, for cancer patients, one treatment strategy may give a much better tumor control, but the toxicity is high. The quality of life is not very good. And another solution could be like, much better quality of life, but the tumor control might be worse. So different patients may choose different solutions, and different physicians also may have their own personal preference. Some physicians are more aggressive, some physicians are more conservative, right? So that kind of noise in the data labeling or in the treatment solutions is kind of inherent, and it's not going to disappear no matter what you do, right? So essentially, I'm trying to say here, yeah, you can reduce the noise in type A, but for type B, in the near future or never, you'll be able to reduce the noise in a meaningful way. So don't try to lock a group of expert physicians in a room, force them to agree on certain things. That's not going to happen, and that's not going to work, right? And also don't try to say, hey, I train an AI model, I can tell you, what to do for this patient, and they are not going to listen to you. So we have to respect this type of noise, type B noise, when you try to deploy AI in the clinical practice. Otherwise, it's going to be a nightmare. I'll tell you why. Next slide. So why you have type B noise? Because medicine is still an art in many cases. Medicine is not science in many cases. Evidence-based medicine and clinical guidelines only give physicians the floor, not the ceiling. So there is room for physicians to exercise their own judgments. Therefore, there are variations in their clinical practice, right? Like I said, there's no ground truth sometimes to tell you which solution is the best. And also there's a trade-off caused variation. So next slide. So I use one example to illustrate what I'm trying to tell you here. This is called a post-operative post-cancer clinical target volume, CTV, segmentation. So basically for late-stage post-cancer patients, the prostate gland will be surgically removed, but there will be still some residual tumor cells in that region which are not visible in the images. But we still want to deliver radiation to kill those tumor cells in that area. In order to deliver radiation, you need to have a target for the radiation beam focus on, right? So that target volume is called a clinical target volume, CTV. So that's a segmentation problem, but it's a very different segmentation problem from the traditional ones, where you have an organ with a boundary defined by the image contrast, that kind of stuff, right? Here, there's no real object there. There's no such boundary there, right? So that kind of segmentation has to be based on a lot of information beyond the image itself, such as the relationship, that's the with other organs, and pathology reports, pre-op MR images, and many other things, right? So there are like many clinical guidelines to tell physicians how to draw this CTV for the treatment, right? But even with the same guideline, physicians, for example, here I'm showing you example, right? Here, if you can you see the mouse cursor? Yes. No? Anyway, so I'm trying to see, show you like if you look at those images, each one has like 4 contours, right? Each one has 4 contours, and from 4 different physicians working in the same hospital, in the same group. They are all GU radiation oncologists, and they all follow the same clinical guideline. But you can still see the difference, the variations among them, right? So next slide. So first, we developed this simple deep learning model we call the anatomy-guided multitask network, and to auto-segment CTV, which we got reasonable results. Next slide. So we did the observer study. We compare our AI results with medical residents results. Those are physicians in training, right? So they are trainees, considered very inexperienced. So here, those are the DICE scores, residence DICE score minus the model DICE score. Most of the time, it's negative, showing AI is doing a much better job than those junior physicians who have not finished their clinical training yet. So this kind of variation or noise from those junior physicians belongs to type A. That kind of noise can be removed with further training, right? Or with AI's help. Go to the next slide, please. And then we did another observer study. We have, this time the observers are experienced practicing physicians. These are the 4 physicians working in the same group, in the same hospital, right? We presented them with 2 CTV contours and background images. One from AI, one from the patient, the ones they used for the patient treatment. So this is a retrospective study. So one is an AI contour, the other one is the clinical contour they used to treat the patient. And we presented them in a randomized, blended way, so they don't know which one is which. And we asked them to give a score from 1 to 4 for each contour. 4 being it's perfect. We can use it for patient treatment now. 3 means minor changes needed. 2 means major changes, and 1 means it's just totally garbage, right? So we also asked him, between these 2 contours, which one was the one you used to treat the patient. So next slide. We found out when they look at their own contours, their own work, even though they did not know that was their patients, because like I said, it's anonymized, blended, right? They still like it better than AI's contours. They give an average score of 3.4 versus 3.2 for AI. And 60% of the time, they thought their work was better than AI's. But still, 40% of the time, they like AI work better than theirs. However, when they look at their colleagues' contours, the colleagues they work together every day from the same group, they gave 3.1 versus 3.3 for AI. And 75% of the time, they thought AI did a better job than their colleagues who work together with this person every day. So that's very interesting. Apparently, there is a clear variation among this group of physicians in terms of CTV segmentation. So then, next slide. Then we were trying to find out if this physician style consistent or unlearnable. So we trained a classifier using physicians' names as the labels, and we found out we can achieve 87% accuracy, which means you can, if you give the computer this image and the CTV segmentation, the computer can tell you which physician did the work. So that kind of style is there, it's clearly there. Next slide. Then the next question is, what is the difference in the treatment outcome and toxicity? So we did the statistical analysis and did not find any difference statistically significant, which is good because there are so many confounding factors when you treat cancer patients, and this is just one with so many, so you cannot find difference in outcome. But then the problem is, if there is no difference in outcome, you cannot convince any of them to change their own style to other people's style because they are quite arrogant. If you have worked with physicians, you know that. They always claim this is their patient, they know how to treat this patient. Don't tell me what to do, right? Unless you have a strong evidence. Go to the next slide, please. So then we developed this another simple model called PSA-led. So it's a ULED with like a same encoder, but different decoders. One decoder corresponding to one physician, right? You train this model to get all the physicians' data to train this model at the same time. So if you go to the next slide, then we found out, for example, if you look at the image on the right bottom, the red contour is from the physician, him or herself. Then if you use all physicians' data to train the AI model, that gives you the blue contour, which is different from what this physician wants, right? And then if you deploy this in the clinic, every time they have to manually revise what you give them. And after maybe a few days, they will say, hey, I just gave up. This is not helping me, right? This is terrible. So that will be considered a failure of the clinical deployment of AI. No one is going to use your tool or product, right? However, with PSA-led, we can generate exactly what this physician wants. That's in pink, right? So that will hopefully they will like it and use it in the clinical practice. So next slide. We test this with an external data set, Mayo Arizona State. It shows the same effect. This idea works. Next slide. So basically, this is just one example, clinical target volume segmentation for, cancer radiotherapy. But in medicine, there are many problems, many situations like this. There is no one single base solution. Physicians will do whatever they think the right thing for the patient. So when you deploy AI to help them in the clinic, what do you do, right? If you gave them what you think, you say, hey, I have a group of the best experts in this field. I train the AI model with a lot of clean data, right? Now, I offer this, AI result. You can just trust it and use it. If this is what you have been thinking, I can tell you this is not going to work. Most physicians will say, hey, don't tell me what to do, right? So then we think the best way to deal with this type of physician style problem is to first, you need to give them what they want by default. Secondly, with a mouse click, they can access how other experts would treat this same patient with a mouse click. Like in this case, for CTV segmentation with a mouse click, they can see how other people would segment this patient's CTV, right? That is useful when they are not very sure about how to handle this patient, or when they are kind of junior, inexperienced. This is a very good learning process, we believe. In long run, the practice will still converge with the help of this type of tools. But for now, in order for you to implement AI in the clinic, for physicians to use that every day, you need to respect type B variation among physicians. So this is next slide, and this is my talk. Thank you for your attention. Any questions?
Thanks, Steve, for the great talk. So, for shedding some light on the noise in the data that you have to work with, right? And this is not just coming from inconsistencies in the data, but also from physician choices making trade-off between toxicity and outcomes, for example. And just trying to understand from that perspective of you said you need to respect that noise. So what does that actually hold for, like, moving forward? Like, is there a way to resolve this where multiple physicians, you said don't lock them in a room and force them to do something, but how do you actually resolve that conflict? Or is that something that you just have to live with and try to work around?
I think you have to live with it for a long time, or if forever, right? Because like I said, the difference does not have a statistically significant correlation with the clinical outcome. Therefore, you cannot convince them to change. But the difference is big enough so that if you do not give them what they want, they are not going to use your AI product, right? But it's not big enough to show them there is a consequence in the outcome. So that's a dilemma, right? Unless you have 1 million patients in a clinical trial, maybe you can have that kind of resolution to show, okay, this difference in your target segmentation will cause this type of noise or toxicity, right? Otherwise, it's not going to happen, I believe. Again, and there's also a difference in, how to deal with different trade-offs. Like I said, some physicians are more aggressive as, hey, I just want to save your life. You may have to stay in bed for the rest of your life, but that's what I think is right thing to do. But some physicians may, respect or may talk to patients. Maybe you won't be able to live for too long, but your quality of life is good. You can still travel to say the word, for example, right? So how do you deal with that? That's just personal preference. That kind of variation is inherent, right?
Right. Thanks for that answer, Steve. So, one question from the audience. One moment.
Steve, this is Christopher. I work closely with Tim these days. I hear him tell a lot of stories, and one of the things he told me is that you were always very clear-minded as early as 10, 12 years ago, that the application of neural networks to medical AI, specifically radiation oncology and so on. Can you tell us what you saw back then that helped you set out such a clear and successful research direction?
Well, we started with GPU, right? That time it was called GPU. So it was like 2007, 8-ish. We were trying to use GPUs for so-called personal high-performance computing to solve some medical problems, because there are some computational intensive tasks in the clinical practice, right? If you can make them much faster, like real time, then you can have a new procedures to treat for the same medical operations, right? So that can come up with much better outcome. So that's what we have been doing, or we were doing around that time, and we were one of the earlier collaborators with NVIDIA in that area.
Right. Let me just see if there are any other questions from the audience. Just one moment.
Thank you, Professor, for sharing. I have a follow-up question around the regulatory environment surrounding this kind of cutting-edge research. Right? So could you explain to us or share with us what are the key maybe constraining policies that you need to be aware of around the capturing and the sharing and the usage of this kind of data and the associated expertise?
it's quite complicated, right? When you talk about regulatory issue, it's also difficult for hospitals to share their patients' data to industry because they are patient privacy issue, right? There also are other reasons. Nowadays, everyone knows data is the gold mine, the oil, right? So it's much more challenging now to get data from other hospitals, but people are working on federated learning, all this kind of stuff, right? So that may help. But overall, I would say it's a tedious process. It's very challenging. You have to go through IRB. You have to go through, the whole process. Of course, you have to anonymize the data, right? Remove all the, PHI, all the patient's information. But even that, it could be challenging when you, like for example, like one problem we had was, when you look at the patient's MR, CT data, if it's tumor is in the head or leg area, right? You can reconstruct patient's face from those images, right? So how do you handle that, right? So, yeah, not easy.
Thank you, Professor. So I can imagine the effort behind collecting even 300, 500 samples of that level of detail.
Yeah.
Awesome. This is great. Thanks, Steve, for this great talk and answering questions. Sorry about some of the glitches as well, but thank you for your time. Thank you all.
Thanks. Bye.